Hi, today I'm going to present the case of Mrs. Kent. Mrs. Kent is a 56-year-old woman with a history of diabetes and hypertension who presents urgently today with a new onset of chest pain for 2 weeks duration. Mrs. Kent was in her usual good state of health. She was diagnosed with diabetes 2 years ago when she presented with high blood pressure, increased thirst, and polyuria. It has been since controlled with metformin. She was also diagnosed with high blood pressure 3 years ago, which has been controlled with ramipril. Today, Mrs. Kent presents to the clinic with chest pain, which she has been noticing during her morning walks. Her pain is located at the center of her chest. It is aggravated with exertion, and it is relieved after 5 to 10 minutes of rest. She described the pain as a heaviness and as dull. She reports the pain to be severe, and she feels nauseated when the pain appears. The pain also radiates to her left arm. She denies any palpation, weakness, or dizziness. She tried Advil or Tylenol prior to her morning walks to see if it would prevent the pain, but no change. Before 2 weeks ago, 2 weeks prior to this clinic visit, she never experienced pain in her chest before. She has diabetes, which is controlled with metformin, and hypertension, which is controlled with ramipril. Her father died of an MI 65 years ago. She is a non-smoker. She exercises at least 4 times weekly and more if she has time. She feels short of breath on exertion, denies any cough. She denies abdominal pain, feels nauseated when the pain is there, and no vomiting or diarrhea. No radiation to her jaw or her neck. No pain in her shoulder or her back. She reports feeling anxious. In her mom's side, there's no cardiovascular problem. She has no known allergies. Her medication is metformin 250 milligrams BID, ramipril 2.5 milligrams daily, atorvastatin 10 milligrams daily, and Ativan 0.5 milligram at bedtime if needed. Her past medical history, as said earlier, she has diabetes, which has been controlled, and hypertension, which also has been controlled with medication. She said she has anxiety, and she takes Ativan when she needs it. Her last blood work was 2 months ago, prior to this visit clinic, and everything came back normal. She's a lawyer. She has been practicing 25 years. She lives with her partner. She has no children. She said she has good support from her family and her friends. She was a smoker 25 years ago, but stopped for 25 years. She has alcohol occasionally, just for events. For her objective or physical exam, she looked well. Her skin was pink, warm, and dry. Her heart rate was 95. Her blood pressure was 131 on 78. Her rest were 20. Her oxygen saturation was 98% on room air, and her temp was 36.8. She has no increased work of breathing. Her breathing is regular. There's no audible sound heard. Her trachea is palpated at midline. There's no use of accessory muscle. No cyanosis or pallor. Her thorax is symmetric with 2 centimeters expansion. The ratio of her AP diameter to the lateral chest diameter is 0.8. There's no tenderness on palpation. The fremitus is symmetric, and on percussion we can hear resonance. The extent of her diaphragmatic excursion is 4 centimeters, and on auscultation, vesicular breath sounds are heard, and no adventitious sounds are heard. Good air entry bilaterally. Her cap refill is immediate to her upper extremities. Her brachial and radial pulse are 2+. Her pulse, pulpitial dorsalis pedis, and posterior tibial pulse are 2+. No pitting edema or edema, and her cap refill to her lower extremities is also immediate. Her carotid pulse is visible. The amplitude of her carotid pulse is normal. There's no bruits. Contour of the pulse wave is upstroke is brisk, smooth, and rapid. The summit is smooth and rounded. There's no trills present. The GVP is 4 centimeters above the sternal angle with the bed elevated at 30 degrees. Her PMI is tapping, brisk, and small, 1 centimeter lateral to the mid-clavicular line in the 5th intercostal space. The S1 is louder than S2 at the apex, and the S2 is louder than S1 at the base. No murmur or extra sounds were heard. The abdomen is symmetric and flat. There's normal aortic pulsation visible. No Broods is here. Active bowel movement sounds to the 4 quadrants. No guarding tenderness or masses on palpation. The width of the aorta is 2 centimeters. In summary, this is a 56-year-old female who presents with a new onset of chest pain that is worse on exertion, is relieved with rest, no history of same. She has a history of diabetes and hypertension, some anxiety that she takes Ativan to relieve, history of heart disease on her father's side. Blood work was normal 2 months prior to this clinic visit, and her physical exam is completely normal. Diagnosed that we can likely think of is stable angina. And other diagnosis we can consider is pulmonary embolism, pleuritis, costochondritis, esophageal spasm, and anxiety disorder. Thank you.